Good day, this is Dr. Farah. Today I will be giving a conceptual demonstration on the treatment of hyperphosphatemia in a patient with chronic kidney disease. I'd like you all to please jot down some notes because during the course of the demonstration I will be integrating some scenarios which can be potential exam questions in your upcoming USMLE Step 3 as well as ABIM. So before describing the therapeutic approach of hyperphosphatemia, I want you all to remember the conceptual definition of CKD based on lab stratification. How will you determine and label and justify that the patient has CKD? What test will you do? Definitely you will go for a GFR. If a GFR is below 60 ml per minute, then definitely this patient is CKD. CKD has 6 stages. I will not talk about CKD. Maybe in a near future demonstration, yes, I will be giving a lecture on CKD, but for right now, you can just remember that when the GFR falls below 60 ml per minute, it's CKD. And CKD has several causes. It can be pre-renal, it can be renal, it can be post-renal. The renal causes can then again be divided into 2 types, a glomerular, which can be nephrotic or nephritic, and tubulointerstitial, which can be, for example, nephrocalcinosis, sarcoidosis, polycystic kidney disease. And then again you have to definitely further investigate the actual cause of CKD. You have to go for other tests like quantitative tests like 24-hour urine albumin or 24-hour urine total protein and urinary sediments, imaging, biopsy. But for right now, you have to understand that CKD is diagnosed when GFR is below 60 mg, and the second marker that determines CKD is the ACR. What is ACR? It's urine albumin creatinine ratio less than 30 mg per gram. Please write this down. When the urine albumin creatinine ratio is less than 30 mg per gram, or the other unit is when ACR is less than 3.5 mg per mole. ACR determines kidney damage. And what does GFR determine? It determines the kidney function. So these are the 2 basic markers to claim patient CKD. Now, what is normal serum phosphate level? It's when the patient's serum phosphate is 3.4 to 4.5 mg per dl. Now, when does hyperphosphatemia start appearing in the serum? Does it appear when GFR falls below 60? No, it appears when GFR falls below 40 ml per minute. Hyperphosphatemia is evident when GFR falls below 40 ml per minute. Right? So now why are you so much concerned about hyperphosphatemia than any other marker, like than any other hormonal imbalance or vitamin D or any other electrolyte or calcium? Why are you so worried about the hyperphosphatemia? What do you have to save the patient from having? You have to save the patient from having complications. The main complications there are 3 main complications. One is the cardiovascular mortality. Cardiovascular mortality in a patient with CKD, what are the 2 main risk factors that are responsible for increased cardiovascular mortality? Well, definitely, yes, it is hyperphosphatemia, and the other one is hypercalcemia and hypocalcemia. Both calcium imbalance is responsible for cardiovascular mortality, and hyperphosphatemia is also responsible for cardiovascular mortality. Now, among these 3, which one causes the calcification in the coronaries and the heart valves? It's hyperphosphatemia and hypercalcemia. Now, if calcification occurs in coronary system, this is an alarming risk factor. Why? Calcification is responsible for acute coronary event in near future. So calcification stratifies a strong risk factor for a near future acute coronary event, and you do not want the patient to have acute coronary events. So hyperphosphatemia and hypercalcemia both are responsible for calcification in the coronaries and the valvular valves of the heart. Okay, now how does this occur? It occurs by gene expression mutation. So calcification in the heart valves and calcification in the coronary occur by hyperphosphatemia and hypercalcemia, but how? By mutation in gene expression. It's basically the osteoblast-like profile that is leading to the valvular calcification. Now, how will you justify that the patient does have calcification? So this is a exam question. It can be a potential exam question. So calcification is justified by performing a radiological test by the name of electron beam CT scan. Electron beam, BEAM CT scan is also known as 5th generation CT scan, and it's also known as ultra fast CT scan. Now, if calcifications are seen in the media via this test, this stratifies a strong risk factor for acute coronary event. And if there is no calcification on electron beam CT scan, then it means that patient is free from acute coronary event. This is very, very important. So once GFR is below 60, you go for these 3 markers: calcium, PTH, phosphate, vitamin D. Why? You have to prevent the patient from hyperphosphatemia, from hypercalcemia, from secondary hyperparathyroidism. Okay, now this was cardiovascular mortality, which is because of hyperphosphatemia and hypercalcemia. Now you know that GFR, we have to measure the GFR via studying the patient's serum creatinine. There are other markers but in USA the most commonly used marker to evaluate kidney function is serum creatinine and also creatinine clearance. There's a less commonly used marker which is known as cystatin. I want you to remember this: cystatin, cystatin C, cystatin C. It also evaluates kidney function. Now, hyperphosphatemia can cause all of these, is responsible for cardiovascular mortality, and hyperphosphatemia is also responsible for a secondary hyperparathyroidism. Now, secondary hyperparathyroidism can occur when the GFR is less than 60 ml, but secondary hyperparathyroidism can lead to renal osteodystrophy when the GFR falls below 40 ml per minute. Please remember this. Now, secondary hyperphosphatemia occurs in response to a series of abnormalities that initiate and maintain PTH secretion. The main abnormalities that contribute to the pathogenesis of secondary hyperphosphatemia are phosphate retention. Phosphate retention is the initial trigger for causing what? The mineral bone disease in secondary hyperparathyroid patients and eventually renal osteodystrophy. Okay, now phosphate retention is the initial trigger for at the end of the day, phosphate retention is the initial trigger for renal osteodystrophy. Now, what happens and how does it happen? How does phosphate retention cause a secondary hyperparathyroidism? Okay, phosphate starts retaining in the kidneys, and what does happen? What does it do? The decrease formation of active vitamin D occurs. Calcitriol is decreased, the active form 1,25-hydroxy vitamin D, and this eventually leads to decrease in calcium level, hypocalcemia. And phosphate retention is also responsible for increasing the PTH gene expression. Phosphate is not increased in the initial stages of CKD. Why? Because what happens when phosphate starts increasing in initial stages, at that time the PTH and another gene which is very favorable for maintaining phosphate hemostasis known as FGF23, please write this down, FGF23 and PTH in the initial stages of chronic kidney disease, they do not allow phosphate to raise. and this does not allow increase in phosphate reabsorption. PTH and FG23 protect hyperphosphatemia. So the initial elevation of PTH is favoring the phosphate hemostasis, and hyperparathyroidism, which is increased PTH, it tends to correct both the hypocalcemia caused by phosphate retention and the calcitriol deficiency, which was caused by phosphate retention, which I just mentioned. So increased PTH, hyperparathyroidism, corrects hypocalcemia by increasing bone resorption. Increased PTH, hyperparathyroidism, also corrects calcitriol deficiency. How? By stimulating 1-alpha hydroxylase. So this, what does it do? 1-alpha hydroxylase stimulation increases the conversion of 25-hydroxy vitamin D into 1,25-hydroxy. This is how compensation occurs. Now, among patients with severely reduced GFR, which is below 30 ml per minute, PTH inhibits the proximal tubule reabsorption from normal 80 to 95% to unfortunately 15% of the filtered phosphate load. So now, despite this seemingly beneficial adaptive increase in PTH secretion, hyperparathyroidism becomes maladaptive over the long term. So now when the GFR falls, PTH cannot do anything. It cannot ensue its protective effect. At a stage when the GFR falls in CKD, PTH loses its functionality and becomes maladaptive, and then what happens? The normal phosphate hemostasis becomes deranged, and PTH then does not have that power to maintain the normal phosphate hemostasis. Now, as I have mentioned, the effect of PTH on phosphate balance changes as GFR declines, and when GFR drops below 30 ml per minute, this compensatory increase in the levels of PTH and FG23 become inadequate. Both PTH and FG23 become inadequate. They do not have the power to control hyperphosphatemia, and this eventually exacerbates hyperphosphatemia. Now the next thing I want you to remember is the role of FGF23. This is extremely important. FGF23 primary function is to maintain normal serum phosphate concentration. How? By reducing renal phosphate reabsorption, and it also decreases co-transporters in the proximal tubule, which lead to reduced phosphate reabsorption from the urine and increases the urine phosphate excretion. So it has the power to excrete the extra urinary phosphate excretion. Now, in kidney injury, when this gene starts increasing, it releases from the osteocytes as well as osteoblasts, mainly osteocytes. The FGF23 has the ability to inhibit 1-alpha hydroxylase enzyme. Once this enzyme is inhibited, the kidneys cannot make active vitamin D. Decreased calcitriol synthesis occurs by the kidney. When vitamin D decreases, this decreases the intestinal absorption of phosphate. Vitamin D acts on the intestine and no more phosphate is being absorbed. So concentrations of FGF23 increase soon after renal injury and progressively increase as kidney function worsens, and possibly as physiological adaptation to maintain normal serum phosphate by enhancing excretion in the urine. The negative effect that is that it trades off the reduced calcitriol concentrations. It reduces the active vitamin D. And this reduction is the initial trigger for increasing PTH production. So FGF23 at a time comes that it no longer is beneficial for the body. FGF23 enhances the sodium and calcium reabsorption, as I have mentioned. So once this happens, it clinically manifests with the renal sodium retention, which clinically manifests with volume overload, edema, hypertension, and FGF23 also affects the heart. It causes ventricular hypertrophy. Please remember this, FGF23 causes ventricular hypertrophy. Okay, and this is very important. And so this FGF23 is an independent risk factor for left ventricular hypertrophy and mortality in